Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will continue in the lower limb trauma in the lecture 3 and begin with the proximal femoral fracture in children. The hip fracture in children is rarely occur, but if occur it has potentially a very serious complication because of the vascularity of the femoral head and the growth plate problem. It usually occurs due to high velocity trauma, such as falling from height or road traffic accident. Sometimes the pathological fracture due to bone cyst or bone tumor may occur in this site. Risk for complication in such injury is due to a vascular necrosis, as I mentioned, because trivial blood supply to the head, and premature physeal closure, and or affect the greater trochanteric apophysis, which lead to coxavara. As we know, between the age of 4 and 8, there is trivial blood supply to the head from the ligamentum teres, which make it liable for the ischemia. The Dolbit classify the proximal femoral fracture in children into 4 types. Type 1 is the physeal separation or subcapital fracture. Type 2 transcervical. Type 3 basal cervical fracture, and type 4 intertrochanteric extension. This will guide the kind of treatment, and the treatment should be done urgently to avoid complications, and certainly within 24 hours. Non-displaced fracture usually treated conservatively in plaster spica or hip spica for 6 to 8 weeks. And displaced fracture type 4, which is intertrochanteric fracture, can be managed conservatively, close reduction with image intensifier, and apply hip spica, and careful follow-up for every 2 weeks to maintain reduction. Displaced type 1, 2, and 3 are usually treated by close reduction and internal fixation with image intensifier, either smooth pins or cannulated small screws to avoid violation to the growth plate. In small children and immobile and uncontrollable children should be the fixation augmented by the hip spica. Other subject is the subtrochanteric fracture in adults. It is very important fracture. It has several features. Number 1, the blood loss is greater than that the intertrochanteric and neck femoral fracture. Number 2, there may be subtle extension into the trochanter and piriforms, and this will alter the kind of treatment and modality of fixation which needed. Type 3, because of strong muscle action around this area, as the proximal part is abducted and external rotated by the gluteus muscle and flexed by the psoas, and the distal part is adducted and overlapped because the action of the adductors. So this will result in difficulties during close reduction and modality of fixation. Clinical feature: as for this intertrochanteric fracture, the leg is either in neutral or external rotation and looks short, and thigh is markedly swollen, and it is more painful than the intertrochanteric area. X-ray: there may be transverse fracture or oblique or spiral or comminuted or even reverse oblique. 3 important features should be looked for in the presence of any will influence the type and modality of the fixation. Number 1, unusually long fracture line extending proximally toward the greater trochanter and piriform fossa. This will alter the type of treatment. Other is the large displaced fragment, which including the laser trochanter. This will affect the stability of the fracture even after fixation. and we should search for any lytic lesion. Lytic lesion. As we know, the subtrochanteric area is the settle site for the metastasis. So the pathological fracture should be excluded. So any piriformis extension or laser trochanter or medial comminution, especially extending into the calcar femorale, and if there is any subtrochanteric lytic lesion should be excluded. Treatment for subtrochanteric fracture. The first of all, sometimes be part of major trauma, so should assess the patient as a whole. Then local control is traction may be helped to reduce the blood loss and pain. Especially if the elderly with multiple medical problems, it's stabilized and prepare for surgery. Overreduction and internal fixation is the treatment of choice with different modalities of fixation, as in this is the dynamic hip screw, and this is the proximal femoral nail or gamma nail, and this is the locked plate fixation. Other is the obsolete option is fixed angle implant, which called L-plate. There is no rule for conservative treatment in such injury unless medically and surgically unfit patient. Otherwise, the fixation is a must. Complication of subtrochanteric fracture including malunion and non-union. Malunion is usually in varus, rotational malunion. It's fairly common. Non-union, this occurs in about 5% of cases and may need to be corrected in redo fixation and bone grafting. Other subject is the femoral shaft fracture. The mechanism of injury of femoral shaft fracture usually in young adult due to motor vehicle accident or fall from height. It means high energy injury. In elderly, any fracture femur should be considered pathological until proved otherwise. And this occurs due to trivial trauma, especially in catching the blanket and fall on the ground. Clinical feature, there is swelling, deformity of the limb, and any attempt to move the limb is painful, with the exception in elderly pathological fracture, it's usually painless. As we know, it's a major bone fracture, result from high velocity injury. So in the management of such injury, we should follow the Atlas and ABC protocol, exclude other injuries, and then go for the femoral fracture. Keep the patient in traction with simple splint to control pain and reduce the bleeding and make transfers easier. We use a fixed splint device. It's a Thomas splint. Other problem is the shock should be treated. As we know, the patient may lose about 1,050 into 2,000 ml of blood, and then the definitive plan for fixation is judged accordingly. The isolated femoral shaft fracture. First step is traction, bracing, and spica cast, especially in children. In rapid manner, I will mention the modality how to hold the fracture. As we know, and the principle is to reduce, hold, and begin exercise. The method to hold the femoral shaft fracture, first of all, is traction, indicated in children, or if there is any contraindication to anesthesia, or lack of suitable skills or facilities for internal fixation. It means it is temporary, then plan patient to transfer to other center which has these facilities. Plate and screw fixation. Use either fracture at either end of the femoral shaft, especially if have intra-articular extension, or in the shaft of a growing child, and if there is fracture with vascular injury which requiring repair. Sometimes we can use external fixation. Other is intramedullary nailing, as I showed in the previous photos. Other modality is external fixation, as you take it in the introduction to the orthopedic and trauma, which indicated into treating a severely open injuries, Gastillo 3, and management of patients with multiple injuries, where there is need to reduce the operating time and prevent the second hit metabolic response to trauma. And then they need to deal with the severe bone loss by technique of bone transportation. The external fixation is also useful, not an AO external, more advanced as in orthofix or Elizarov, which called bone lengthening and bone transportation procedure. And then treating femoral fracture in adolescent. Treatment of open femoral fracture should be carefully assessed for skill loss, wound contamination, muscle ischemia, which apparent through the wound, and if there is associated injury to the vessels and nerve. This is the modality of fixation. This is the external fixation, and this is the intramedullary nail. This is a plate and screw, and this is the bridging plate. This is the bridging plate. Avoid the shaft of the femur to maintain the fracture hematoma. A rapid manner, the Winquist explain the classification for the femoral shaft fracture depending upon the size of butterfly, which is mean comminution, and size of the piece, which incorporate the width of the femur, into 4 types. And this is the details of the classification. Complication of femoral shaft fracture is important, very important, because it should face daily in the emergency department, including early and late complication. Early complication is the shock. As I mentioned, 1 to 2 liters of blood can be lost within the closed fracture. Other is the fat embolism syndrome. As we know, the femur is the large marrow-containing cavity and almost inevitably result in small showers of fat emboli being swept in the lungs and cause fat embolism and collapse. Other is the deep vein thrombosis, especially in delay treatment of the fractures. Prolonged traction in bed predisposed to DVT. So the third principle of the fracture management should be applied. So early movement and exercise are important to prevent this complication. And sometimes we use DVT prophylaxis, whether mechanical or chemical. Other early infection is especially in compound injuries. Late complication, delay union and non-union, malunion, joint stiffness, especially the knee, and refracture and implant failure. Okay, other subject is the femoral shaft fracture in children. Mechanism of injury: if the patient is below 2 years, the commonest cause is child abuse. And we are searching for as we do bone survey, searching for other several fracture in the body with different stage of healing. Other is the pathological fracture, which has common generalized disorders such as spina bifida and osteogenesis imperfecta, or sometimes pathological fracture due to cystic lesion, local bone lesions. Treatment: usually traction and cast. Infant need no more than a few days in balanced traction, which is called gallows traction, then followed by spica for 3 to 4 weeks. 2 to 6 years is conservative. But 6 to 10 years is the gray zone for conservative or surgical treatment, according to the patient weight, according to the situation, kind of fracture. So these can be treated either by balance traction for 2 to 3 weeks, followed by spica cast for another 4 weeks, or early reduction and spica. Shortening for 1 to 2 cm and angulation up to 20 degree are acceptable. Teenager requiring somewhat longer 4 to 6 weeks in balance traction. The limit of acceptable angulation in this age group is 15 degree in AB and 25 degree in lateral. So angulation little bit to be accepted. Surgical options including fixation with the flexible intramedullary nail or Nancy nail, or rigid trochanteric entry intramedullary interlocking nails, or even we can use blatant screws or external fixation. This is the flexible intramedullary nail, and this is point of entry to avoid crushing devices at the margin, and this is the trochanteric entry intramedullary nail. Complication of femoral shaft fracture in children, including shortening up to 2 cm is acceptable. Other is malunion. Malunited fracture for 2 years before offering corrective osteotomy should be observed. Other very important subject is the supracondylar fracture of the femur. In youngs, usually due to high velocity injury, either in road traffic accident or fall from height. An elderly osteoporotic fracture is usually due to trivial trauma or simple twist. Clinical feature: the knee is swollen because of hemarthrosis, and this can be severe enough to cause blistering later on. Movement is too much painful, and the tibial pulse should be always checked because swelling or sometimes associated with popliteal artery injury. X-ray: factors that influence the type of internal fixation, whether the fracture into the joint line is comminuted or not, the size of distal fragment, and whether the bone is osteoporotic or not. This will affect the kind of and modality of fixation, and this is shown in the X-ray. The type of supracondylar fracture, either extra-articular or unicondylar, or Y type, which is intercondylar extension, and according to this type may have comminution in the fracture site according to each stage. Treatment of supracondylar fracture: non-operatively by traction if the fracture is only slightly displaced and extra-articular, or if it's reduced easily with the knee flexion for 4 to 6 weeks. Little bit not used this manner. Almost all patients need surgical intervention. Operative treatment with internal fixation can be enabled accurate fracture reduction, especially if the joint surface is comminuted, and permit early rehabilitation. Sometimes this is called the fracture of necessity because it has intra-articular extension. Several different devices available for fixation is the locked intramedullary nail, specially indicated in extra-articular fracture, blade and screw that's applied to the lateral surface, especially the locked blade, or traditional angled blade, or 95-degree condylar screw blades, or sometimes if unicondylar fracture we can use simple lag screws, just only screws. Complication including early arterial injury in around 5 to 10% of cases and should be excluded by checking the distal pulse and ankle brachial pressure index, and sometimes we need CT angio or even arteriogram. Late complication is the joint stiffness, especially in intra-articular extension or delay physiotherapy, malunion and non-union. Other important subject is in children is the fracture separation of the distal femoral physis. According to the Salter and Harris classification, we have 5 types: separation of the epiphysis through the transverse through the physial plate. Type 2 is extension into the metaphysis. Type 3, extension into the epiphysis. Type 4, including epiphysis and metaphysis. And type 5 is the crushing of the physis, which is usually diagnosed in retrograde fashion. Clinically, the knee is swollen and perhaps deformed, and the pulses of the foot should be checked. Treatment: the fracture can usually be perfectly reduced in closed fashion, and further X-ray should be checked to assess if there is any further displacement after 1 week. Occasionally open reduction is needed because tethered in the fracture site is the flap of periosteum, which prevent the reduction. Salter hearts type 3 and 4 should be accurately reduced by open reduction and smooth K-wire fixation. Complication early and late, which including vascular injury. Late complication is the physial arrest. If whole devices may cause shortening, because around 70 to 80% of the femoral length depending upon the distal femoral physis, and if one side of the physis is closed, it will cause the angular deformities, whether genovarum or genovalgum. That is all, and thank you.